So, you have a patient. You have a patient who has who comes in, unfortunately, in the third trimester. Pardon me, with for a routine OB check. You go to. She's about 34 weeks, and well, let's say she's 36 weeks. So you go to check fetal heart tone. She does report some slightly decreased fetal movement. You can't detect fetal heart tone, so you get up the ultrasound, and unfortunately, there is no fetal heartbeat. So you diagnose a stillbirth. Tell me, approximately, what's the incidence of stillbirth in this country?
Overall, I want to say 2%, but I'm not sure what the exact number is.
Okay. Can you tell me what risk factors would be for a patient to suffer or experience a stillbirth?
Yes, so a patient with prior history of stillbirth, advanced maternal age, obesity, specifically if the BMI is greater than 40, gestational diabetes, hypertensive disorders in pregnancy, major congenital anomalies. There's so many. And basically, many of the conditions that we do antenatal surveillance for.
Okay. So, what if you have a patient? So let's say you sent this patient to labor and delivery, and you induce her. She delivers obviously a non-viable or stillbirth. What would you do in terms of trying to work the patient up? One, to learn what happened, so maybe preventable in a future pregnancy, and or to try to give the patient some peace of mind. What would you recommend?
So the first thing I do is I get a very thorough history from the patient, specifically if I've, never met her before, but if I was managing her in the pregnancy, I would take the patient's history as well as the history that I have on record to look for any clues or information. I would do a physical exam on the patient. I would be examining the placenta. So I send the placenta to pathology for evaluation, letting them know what the diagnosis was. I do evaluate the fetus to see if there were any fetal anomalies physically, to see if they could give us an idea of what may have occurred, especially with the umbilical cord. I asked the patient if she's interested in doing a fetal autopsy, which I understand has a high cost associated with it. So I do discuss that with the patient, but I do let her know that there is an option of doing that. And if so, I do send the fetus for autopsy. There is another test that you can do by taking a small sample of the Achilles and sending that to evaluate for chromosomal abnormalities or any issues chromosomally if they weren't already discovered in the pregnancy.
So Vanessa, let me
yes.
interrupt for a second. If we were trying to do this a bit methodically, I mean, there's a whole bunch of tests we could get. Can you kind of tell me the order that you would do things in an effort to be, let's say, cost conscious, but I'll say it anyway.
Okay, so the first I would start with a CBC to evaluate for the white blood cell count, look for infection, evaluate hemoglobin to see if there's anemia, platelet count. Depending on the patient's blood pressure, I would do preeclampsia or HELP workup. I would get a fibrinogen as well to see if there's any evidence of abruption or concealed abruption. Pretty much it for labs. If there was evidence of infection, then I would consider doing torch labs, but I don't routinely do torch labs on all patients who have stillbirth. That's what I can think of right now. And then the other things I had mentioned.
So of some of the tests that you talked about, which are going to have or be the most telling, if you will? Do you understand my question? Which one's
Yeah, like what's going to give me the most information?
Well, or point to the most likely cause or rule out, major causes. Does that make sense?
Yeah, I would say in the immediate,
I'm sorry. I lost you.
labs that I would be able to would be like a CBC, for instance, apart from sending the placenta or the genetic screen. But those take time. So in the immediate presentation, I would say a CBC would give me the most information.
Okay. Let's see. All right. Good job. So let's see. I'm going to just call one of your colleagues to see if they have anything they want to add or change. Philip, you're self-muted. Philip? Okay. Scott, can you take yourself off mute? Vanessa, no one wants to talk to us tonight.
What's going on? Nobody's around tonight?
I mean, these are people that are dialed in. Just trying to unmute them, but they're not taking themselves off mute. Well, we'll see if LaShawn, do you want to take yourself off mute?
Yeah, so I was just gonna add like a urine drug tox screen. Sometimes that could be helpful for I mean at my institution we also get like a TSH, hemoglobin A1C, but I mean if this is a patient we didn't know, and I do torch labs. I don't know what you have to say about that, Dr. Green, but I typically do like the more common ones like the HSV, the Parvo, and the CMV. But I don't know. But those are the only things I would add to that.
Okay. Good thoughts. So, I think what both of you said is great, actually. The one comment I would make is, they may look at you or look to you to try to be, again, I hate to say it, but cost conscious. So have a particular order. I mean, torch titers, totally agree with you, certainly could cause it, but wouldn't be one of the first things I get, again, unless the patient had symptoms of some sort of, CMV or whatever. Again, not saying not to get them, but it wouldn't be at the top of the list. So I think we'll go over this. And LaShawn, thanks for weighing in, and Vanessa, you of course as well. So let's go over it. So risk factor or incidence of stillbirth, it's about 1 in 160 in the United States. Thankfully, it's less than 1%. I think your incidence of 2%, Vanessa, that's not something that they're going to go, oh, what's she thinking? If you had said 10%, that would obviously be a problem. But again, less than 1%, 2%, you're in the neighborhood. Some risk factors would include non-Hispanic African-American race, non-Hispanic Black race, nulliparity. You mentioned advanced maternal age and obesity, substance use. So I think to LaShawn's point about the tox screen, certainly alcohol abuse, tobacco would increase the patient's risk of stillbirth as well. You also talked about some medical conditions. You said diabetes, hypertension, congenital anomalies. So certainly hypertension, we'd be thinking particularly of leading to an abruption. If it's chronic hypertension, perhaps placental insufficiency, which may be associated with fetal growth restriction. Again, you mentioned congenital anomalies, so either chromosomal or other anomalies like that, infection. And again, I think that gets to the torch that y'all were talking about. And then, of course, cord accidents can cause stillbirth. So if we're doing a systematic, cost-conscious evaluation, what's going to give us our biggest bang for our buck, pardon the pun, would be sending and you said this, Vanessa, sending the placenta to pathology, obviously inspecting it ourselves. Do we see evidence of where there was a large clot or something like that, resulting in or raising our suspicion for abruption. But placental pathology and fetal autopsy, if the patient will permit it, is going to give us the answer in about 2/3 of cases. And in a further 24, 25% of cases, it will, I'm sorry, that's not true. In another 40%, it will exclude other conditions as contributing. So it's really probably those two things alone are going to give us, by themselves in isolation, are going to give us the, point to the reason in the majority of instances. We certainly could do genetic testing on the fetus. If we do consider that, and we consider APS, neither one of you actually mentioned antiphospholipid.
That's right. That's right.
That'll explain about another 10% of stillbirths. Vanessa, the first thing you mentioned, which kudos to you, was like a chart review or a thorough review of the history. So that's critical. Other things that you could consider, microarray, looking for deletions or duplications, possible screen if you have any suspicion of maternal fetal hemorrhage. And of course, the antiphospholipid evaluation, we would be even more so inclined to do that if the patient had evidence of either hypertension or growth restriction. So that's going to be basically our workup. I thought you guys did a nice job with that.
Thank you.
So I would have definitely passed you on the question. Do you have any questions for me? By the way, guys, we will stop about 10 minutes early at the end. So if y'all have any questions, be happy to try to answer them at that time.
I do have a question, actually. It doesn't even relate to this question, but now that I have you here, typically when we are asked about questions about the vacuum application, even during the course in Baltimore, like it just repeatedly comes up where to apply it. I looked on the manufacturer's instructions for at least the Kiwi vacuum, and they mentioned to place it 2 centimeters anterior to the posterior fontanelle.
That's correct.
Okay.
It's called the flexion point.
Yeah, the flexion point, because I don't know, a lot of people are saying 2 centimeters from the anterior
No.
on the sagittal line.
No, it's in the mid-sagittal line, of course, as you just mentioned, and it's 2 centimeters anterior to the posterior fontanelle, which, if you think about it, makes sense. I mean, not that babies aren't born OP sometimes, but usually they're OA, and so we're basically almost in the middle of the skull if you're 2 centimeters. Slightly maybe toward the back a touch, but you don't want to place it over the fontanelle, obviously.
Right.
But usually we're going to direct the head down just a little bit and then up, obviously. So
okay. I just
kind
wanted to clarify that.
And the highest station you would apply it, by the way, since you asked?
+2.
Correct. Okay, good. Any other questions?
No, thank you so much. Have a good night.
My pleasure. You too. Thank you. Okay, so looking for Dr. Schlieser or Sears. Either of you on, please raise your hand if you are. Here we go again. The elusive doctors for the hot seat. Okay. Dr. Todd or Binstead? Dr. Todd or Binstead, either one of you guys on?
Mic on.
Okay, give me 1 sec. Dr. Binstead, wonderful. I'm trying to unmute you, Dr. Binstead.
Hi, can you hear me?
I can hear you now. How you doing?
Great. I'm doing great. How are you?
Now that you're present, I'm doing much better.
Wonderful.
I was afraid I was going to have to quiz myself. It would be terrible. It'd be embarrassing not to know the answers to most of these things. Okay, so let's talk about a patient
Mic
who
off.
is 35 and 6 days, comes to see you for routine check in the office, and she's complaining of new onset lesions on her soles and on her palms, and she has some itching with it. So she shows it to you, and you are suspicious that she has cholestasis of pregnancy. How common is cholestasis of pregnancy?
So cholestasis of pregnancy occurs in about 1% of pregnancy, so it's not terribly common.
Okay, give me 1 second, just making some notes. So about 1%.
Probably actually less than 1%, but yes, go on.
Can you tell me what are risk factors for patient developing cholestasis?
Risk factors for cholestasis of pregnancy would be our baseline liver disease. Hispanic ethnicity is increased risk of cholestasis of pregnancy. Those are the main two that come to mind.
Okay, so what causes cholestasis?
Cholestasis of pregnancy is caused by an elevation of bile acids.
Okay, why does that happen?
In terms of the exact physiology, I would have to look that up, but my understanding is that it's from kind of like poor motility in the gastrobiliary system.
Okay, so with the poor motility, what ends up happening?
There's sort of like I guess I would have to look that up, the exact kind of pathology there.
Okay, and so if you suspect cholestasis, when does it typically appear?
So it typically appears in the third trimester, after 35 weeks of gestation. I start my workup by ordering serum bile acids and CMP.
I'm sorry, what other findings what other things might the patient complain of and/or findings on your physical exam?
Yeah, so diffuse itching, it's not necessarily on the palms and soles. It doesn't necessarily have to be a rash. They can appear, severe cases, they can appear jaundice. I always ask about fetal movement. I do a detailed history and physical. Those are the kind of main findings that you can see with that.
Okay, and so so you mentioned you're going to get bile acids.
Mm-hmm.
Any other lab tests?
I'd also get a complete metabolic panel. I'd want to check for her, specifically her liver enzymes.
Okay. What's an abnormal bile acid number? Do you know?
10 or greater would be considered abnormal.
Okay. How did the bile acid, so the bile acids are elevated. So how does that affect the pregnancy?
That would give her the diagnosis of cholestasis of pregnancy. There is an increased risk of stillbirth and with that diagnosis. So that would potentially change my delivery timing for her.
So why is there an increased risk in stillbirth?
So I'm not sure if the cause is like clearly known, but I know that there is. And so I would start doing NSTs as well as potentially recommend delivery around 37 weeks.
Okay, so you'd recommend delivery around 37 weeks, but we're not sure why it increases the risk?
Correct.
Okay. Okay, so you said you're going to deliver at 37 weeks?
I do recommend delivery at 37 weeks for patients with elevated bile acids.
Okay, always 37 weeks?
If the bile acids are over 100, there is clinical signs and symptoms of liver failure, abnormal tracings. I would even deliver earlier than that.
So if they're over 100, you said you would deliver earlier, or abnormal tracing. So you tell me about the tracing. Tell me what you mean by the abnormal tracing. You're going to do increased surveillance?
I do recommend twice weekly non-stress tests for patients with this diagnosis.
Starting when?
At the time of diagnosis. So even if I don't have the elevated bile acids yet, if I saw this patient in my clinic and I was highly suspicious she had it, I would start testing.
Okay. Are there any other risks that cholestasis conveys? So can it cause or precipitate or predispose a patient to other complications in pregnancy?
It can there is an association with cholestasis and preeclampsia, from my understanding.
Okay. After delivery, would anything you would do for somebody who had a history of cholestasis?
If they had elevated liver enzymes, I would continue to track them and monitor their blood pressure to ensure that it was normal. But other than that, I wouldn't do anything else in particular.
How would you counsel this patient after delivery?
After delivery, I would counsel them that there is an increased risk of having, if you've had cholestasis of pregnancy in one pregnancy, you have an increased risk of developing it again. And that we would monitor her closely in her next pregnancy. But that delivery should resolve and improve her symptoms.
So what is the recurrence risk?
I would have to look up what that recurrence risk is. I'm not sure.
Okay. What about contraception post delivery? Would this history affect your what you'd offer the patient?
Yeah. So in general, no, it would not. However, the caveat is there are some contraception options that liver disease is a contraindication for use. The contraceptive implant being one of those. So if she had signs of overt liver dysfunction, I would not recommend that option for her.
Okay. Let's see. All right, I think we will stop. We will stop there. Nice job. So let's talk about cholestasis. So the incidence is between 0.2 and 2%. So you said what'd you say, 1%? So
I said, yeah.
You're good. Risk factors, you said liver disease and Hispanic ethnicity. So some risk factors would include multiple gestation, South American or Northern European patients, personal, if they have a personal history or family history, if they're IVF, I didn't know that. Increase it. If they have cholelithiasis, if they're advanced maternal age, and hepatitis C, all would be risk factors for cholestasis.
Okay.
So what happens is the transport of the bile acid from the gallbladder is disrupted, so the bile acids can enter the bloodstream. And the concern is the bile acids can cross into the placenta and obviously get into the fetal circulation. And so the theory is they can cause a fetal arrhythmia, which leads to IUFD.
Okay.
So, you know, again, just as you said, third trimester, typically itching, usually no rash. They can have dark urine, pale stools, things that we would associate with biliary disease anyway. You mentioned the bile acids. The liver function test to be plus minus. If you get a coagulation panel and the coags are abnormal, you should consider other causes. Let's see. You mentioned there can be an increased risk of preeclampsia. That's absolutely correct. Gestational diabetes, there can also be an increased risk of that. Obviously, preterm delivery, depending on the bile acids, meconium, RDS, all can be associated with cholestasis. There does seem to be a relationship between the bile acids and the risk of fetal complications. By that, I mean the higher the bile acids, the higher the chance of association. So, prenatal testing, as you suggested, would be recommended. So, prenatal testing doesn't reduce the risk of stillbirth anyway. Suggest. Weekly bile acids are recommended. I mean, I don't know that folks always do them every week, but that would be suggested. If you have bile acid level over 100, you should be delivered. She's 36, bile acid of 105. She should be induced and delivered right then and there. Otherwise, after 37, they say 37 to 39. Bile acids are above 40. Most people are going to 37 weeks. Most people are push forward that. You mentioned caution with contraception, the liver problem. So you would caution in patients with OCP, combination OCPs. And one thing I read suggests checking bile acids about 2 months after delivery. I've never personally done that, and I haven't really seen anybody do that, but that is what they suggested. The recurrence risk is about 90%.
Oh, wow.
Yep. So it's it can be pretty significant. So do you have questions for me?
I think you answered all of them. Thank you.
And then some, right?
And then some.
Thanks for volunteering and raising your hand.
Yeah, thank you.
You're welcome. So, Dina, you have your hand up. I'm not sure if you have a question or comment.
I was just going to request if we could mute the person making all the noise.
Oh, I think we just did. Are we good?
Sounds much better on our end now.
Yeah, sorry about that. Thank you.
Thanks.
Kirby, or did you have a question? It says you're self-muted if you.
Yeah, I was just going to ask if you could repeat some of the stuff with the person in the background, probably about when you started talking about antenatal testing and weekly bile acids. And I don't think anyone caught the rest of what you said.
Okay, so so the antenatal test, what I said was antenatal testing would start at the time of diagnosis. We do it, but it hasn't been shown to prevent stillbirth. Weekly bile acids are recommended, but they do take several days to come back. And did you all hear about the timing of delivery, Kirby, or do we need to go over that as well?
I think I caught the gist of it. I also lost you when you started talking about post-delivery and contraception counseling after that.
Okay, well, let's just go over it again, just so make sure everybody's got it. Thank you. So again, we would want to deliver, if the bile acids are over 100, we would want to deliver that patient. So, you know, if she's less than 36 weeks, you know, or sorry, less than 37 weeks, you may or may not want to give steroids. You know, some of it would be dependent on the tracing, but that would be a patient I would keep in the hospital to deliver. If the bile acids are above 40, delivery typically is going to be between 37 and 40 weeks for, I'm sorry, 37 and 39 weeks for cholestasis. But if the bile acids are above 40, you're going to want to deliver by 37 weeks. And again, most folks are going to be happy if they get to 37 weeks and call it a day if they have cholestasis of pregnancy, just because of the increased risk. And as we said, the antenatal surveillance, while done, doesn't seem to prevent IUFD. So post-delivery, again, I think I mentioned, never done it myself, but I did read one place where they do recommend checking the bile acids basically at your postpartum visit, so 6 to 8 weeks after delivery, and using caution in starting a patient on combination birth control pills because of liver disease would be a contraindication. So you really want to make sure that the patient's liver is functioning well. And then we did talk about the 90% recurrence risk. So hopefully that answers for folks that couldn't quite hear. So wasn't on my end, but do apologize. So Dr. Brar, you are next on the hit list. You want to raise your hand? Hang on 1 second, guys. Dr. Brar. I don't know if it's you, Bobby, or if it's your wife. I thought I saw you on there earlier. Maybe he found out I was doing the webinar and he hung up. That's so mean. Okay, well, I don't see him now. Dr. Brown, and I don't have a first name. Is there a Dr. Brown on the call? Guys, I will report back to Exam Pro. This is kind of tedious for you guys. Dr. Pasante or Ibizue, either of you. Dr. Curie, there we go. Hi.
Hi, how are you?
I'm so glad you're on. Good, how are you? Are you a generalist or specialist?
I'm generalist.
Okay. Give me a second here. Let's see. Sorry, just be one more second. Okay. So you have a patient who is 22-year-old with a new family history of Lynch syndrome. So what would be your criteria for recommending a patient be evaluated for Lynch syndrome?
So I would get her family history and see exactly which relative has tested positive for Lynch syndrome. If it has been a first degree, like a parent or a sibling, I would recommend she also gets tested. if we had no prior testing on record, but there's history of cancer, like I believe it is, I don't remember right now the exact criteria, but it's ovarian cancer. I think it's one family member with ovarian cancer and history of colon cancer, and then 2 or more relatives with one of like colon cancer. I have to review the exact criteria if we do not have that prior result of Lynch syndrome.
Okay. So a patient with, let's say you end up testing this patient, and it turns out that she is Lynch syndrome positive. What would you recommend for her? How would you counsel her?
Yeah, so I would definitely counsel her that Lynch syndrome increases risk of cancer for a different number of cancers, such as ovarian cancer, endometrial cancer, colon cancer, and gastrointestinal cancer, such as stomach, pancreatic cancer. Main risk is for uterine cancer and colon cancer. So due to this, we usually recommend screening earlier than the average risk population. So in the case of colon cancer, it is starting at age 35, or age 35, every colonoscopy every 1 to 2 years.
I'm sorry, what age?
35.
Is when you would start colonoscopy screening?
Yes, I believe so.
Okay, 35, Q1 to 2 years. Okay. What else?
I would also recommend endometrial biopsies, even if she has no symptoms of abnormal bleeding. I believe it's also once a year. There is no clear recommendation for the screening for the gastrointestinal cancers, but I know there's some recommendation to do CT scans, but it's not clear.
To do CT scan again, looking for which
For
type?
the GI cancers like pancreatic cancer, but it's not clear because it's not one of the most frequent cancers that these patients get. In the case of ovarian cancer, there's also it's not recommended to screen with ultrasounds. So the patients just need to come frequently, like yearly, for exams, for pelvic exams.
And I'm sorry, one more time. When would you screen for endometrial cancer?
Endometrial cancer, I believe, is at age 30, but I really have to review Lynch syndrome because I always forget it.
Okay. So any idea, I mean, would you offer this patient risk-reducing surgery in the future?
Yes, we can offer risk-reducing surgery once the patient has completed childbearing. Otherwise, it's at age 45, the recommendation for Lynch syndrome with hysterectomy and BSO.
Okay. How significant is the increased risk of ovarian cancer? And would you take the ovaries at 45?
Yes. I think the risk of ovarian cancer is about 20%. And yes, I would take the ovaries at age 45 and place the patient in hormone replacement.
Okay. How long would you keep her on the hormones?
So you can keep her until the average age of menopause, which is 51 in the United States, but could consider keeping her longer if the patient's still symptomatic once you decrease the dose or try to stop it. There's no indication of when you have to stop the hormone replacement therapy.
Okay. All right, good. Let's go over it. So more and more these genetic cancers, syndromes can come up on the boards because, you know, obviously more is being found out, more genes associated with particular conditions. So we would offer patient Lynch syndrome testing, which, by the way, you know, Lynch is an autosomal dominant inheritance pattern. Patients, as you mentioned, are increased risk for colon, endometrial, or ovarian cancer, can cause stomach cancer, small bowel, renal, pelvis, and ureteral cancer. So ureteral cancer is pretty unusual, but certainly can. Now, Lynch syndrome only accounts for about 2% of colon and endometrial cancers, but the patients have a much higher, if they're Lynch syndrome positive, the chance of them developing one of these cancers over their lifetime is pretty significant. And you know, the actual risk in terms of percentage depends on which DNA mismatch repair they have. So, I mean, but endometrial cancer range can go anywhere from about 15 to 60%. Colon cancer development by age 70 is about 20 to 60%. So it's pretty significant. Ovarian cancer by age 70, you know, is about 5 to 10%. So not as high as BRCA, but certainly significant because in the general population, as we know, it's 1 in 70, or approximately 1.5% or so. So in any case, let's see. You know, if somebody has a first-degree relative that's diagnosed with Lynch syndrome associated cancer before age 60, certainly could consider offering the patient testing for Lynch. Patients that have a family history of Lynch syndrome associated cancers, if they themselves have uterine or colorectal cancer before age 50, again, would all be, if they have a personal history, again, of uterine colorectal cancer and a family history of Lynch syndrome, obviously those patients would also be candidates for being tested, and you could certainly test their children as well. All right, so Lynch syndrome, in terms of screening, we would recommend patients have colonoscopy colonoscopy every 1 to 2 years, starting between the ages of 20 and 25, or 2 to 5 years younger than the youngest family member, whichever is earlier. The endometrial cancer surveillance basically would consist of endometrial biopsies starting between age 30 and 35, again, every 1 to 2 years. Although we would ask the patient starting in her mid-20s to keep a menstrual diary, and any abnormal bleeding, excuse me, would warrant a biopsy earlier. In terms of ovarian cancer, as you pointed out, there really is no good screening for ovarian cancer, but it is recommended that patients undergoing risk-reducing hysterectomy between 40 and 45 also have their ovaries removed. Things you can do to protect a patient, at least from the endometrial cancer standpoint, would be having her on a progesterone contraceptive, either combination birth control pills, progesterone only, progesterone IUD. All these things would help to reduce the risk. Excuse me. I'm trying to think if there's anything else. Hormone replacement therapy, of course, would be good. You mentioned there's no good way to check them for or survey them for stomach, small bowel, or renal cancer, and that would be correct unless they have symptoms. So there is no preventive, if you will, that is currently recommended. Anything Berenice, anything else that we didn't cover?
I think that's all. The recommendation to test the patient when she does not have a proven Lynch syndrome, you know, like in her family, like, is it like I don't know if there's for Lynch, like a specific, you know, like a relative that has this and that, second degree that has this and that, or do we just base on suspicion? If like, usually what I do is if somebody has a family member that had either colon or ovarian cancer that's younger, I offer genetic screening and genetic counselor. But I know that there's also some recommendations like specific for when we definitely should be sending patients.
Well, so again, if the patient themselves have uterine or colorectal cancer before age 50, they would be a candidate to be tested for Lynch. And, you know, it does make a difference for her, but it makes obviously a bigger difference for her family. If she has colorectal cancer that has weird histologic features like tumor infiltrating lymphocytes or signet ring differentiation, they talk about it. If there's a family history of Lynch syndrome associated malignancy and the patient themselves has a personal history, so not necessarily before age 50, but has a personal history of either uterine or colorectal cancer. But even women with a family history of Lynch syndrome associated cancers, they say it would be reasonable to evaluate them for Lynch syndrome. So anybody certainly that has the cancer, has one of the cancers, meaning uterine or colorectal, or certainly if they have a family history of Lynch syndrome associated cancers, and certainly if there's a Lynch syndrome positive person in the family, they would all be reasons to do the testing.
Okay, thank you.
Thank you. Thanks for volunteering. Let's see. So, oh no, I've got to do it again. Dr. Ibezu, Ibezue, or Ikwu Agwu. Oh, good. Wow. Didn't have to go searching forever. Hold on one second. I don't know how to.
It's fine. It's Ijama.
Ijama. Thank
Yes.
you.
I would volunteer, but I'm actually putting my baby to sleep right now, so I don't know if he's gonna start screaming or not.
Well, at least we'll mark you present. We'll, if you can't do it right now, we'll come back to you.
Okay.
All right. Thank you.
Because
Oops, sorry, I cut you off too soon.
I say yes, because I am here. Just I don't know if he'll make noise. So.
Yeah. No, I appreciate that. We'll come back to you.
Okay.
Dr. Ikwu Agwu, are you here? Yes. Tiffany, you're trying to unmute you. It says you're self-muted. There you go. Tiffany, can you hear me? Oh, let me see if I can unmute you again. You have to enter your PIN. It says you're dialing in. Tiffany, do you have a PIN to enter? Oh no, we're losing Tiffany. Did you want to try to dial back in on your computer? I don't know if you have the other sign in there. Okay. Let's see. Doctors Vizcarra, Zaradskaya, Arbeliz, Della Valle, Islam, any of you guys on? Anybody that is supposed to be in the hot seat, that is supposed to have a chance in the hot seat that hasn't gone recently? Clarissa,
Yes,
are you a hot seat person?
I am. I haven't gone in weeks. I'm not really sure why, but
Okay.
yeah.
I'm not sure either, but I'm gonna, in the interest of moving this along, I'm gonna elevate you now. So, okay, so what, are you a generalist or specialist?
Specialist.
What do you do?
I'm a GYN oncology fellow.
Oh, perfect. Okay, so you have a patient who is a, sorry, it's not displayed here, but you have a patient who is a 25-year-old G1P0 at 39 and 5 days, uncomplicated prenatal course, except for the baby is thought to be a little bit LGA, with an estimated fetal weight of about 4 kilos just at the time of labor. Long story short, she is in labor. She progresses to fully dilated. She starts pushing. She's been pushing for about 3 hours, and she's exhausted. The head is +1 to +2 station, so it's a little high for you to reach, and she's done. So she requests a C-section, which you were contemplating anyway. Anyway, long story short, you go to do the C-section, and you discover, as you go to elevate the head, you discover that the head is deeply impacted. So what's the incidence of deeply impacted fetal head?
It is, I don't know the exact number, but it's more likely when you have been, when you have a second stage arrest and you are performing a C-section for that indication.
Okay. Are they more or less common in emergency C-sections?
I'd say less common.
Okay, just making some notes. What risks are associated with deeply impacted fetal head?
Some risks would include inability to deliver the fetus in a timely manner, and subsequent neonatal morbidity because of that. Extensions, uterine extensions, cervical extensions, all the way down to the vagina. Those could be intraoperative complications, and could also potentially lead to increased blood loss and increased operative time. When you have a second stage arrest with the fetus deeply impacted, the C-section is clean contaminated, and also meaning that you can have an increased risk of infection.
Okay. So you told me some of the things that can be associated or that they can cause, but what are risk factors for deeply impacted fetal head?
Some risk factors include fetal macrosomia, second stage arrest, potential. I am not 100% sure of this, but I believe fetal position, like an occiput posterior positioning of the fetus, a maternal pelvis shape, which would potentially be like arthropoid or anything but gynecoid, could potentially increase your risk for.
How do you do clinical pelvimetry?
I think you have to measure the obstetrical conjugate and the there's pelvic outlet diameters that you measure, and it's not something that you can assess with just a physical exam. I believe it's there are measurements that you would have to take with imaging.
So, okay. I'm going to interrupt for just a second. So I wouldn't say this would be my worst nightmare, Clarissa, but we didn't really do much in the way of formal clinical pelvimetry in training. I mean, sometimes we would do CT pelvimetry in rare instances. But my point is, I would not want to talk about clinical pelvimetry personally. So I'd be careful bringing that up unless you want to talk about it, you know, and the only thing that triggered it was the pelvis shape. You're not necessarily wrong by any means. It's just, you know, unless you can tell me, the next natural question is going to be, how do you do clinical pelvimetry? So, you know, you almost have to anticipate that. And if you can get away without if you're not comfortable talking about it,
Okay.
you know, and you can cover the question without bringing that up specifically, that would be a strategy to take. I mean, that's what I would do.
Yeah.
So I would talk about, you know, you mentioned OP. I would talk about that. Prolonged second stage, you mentioned that. You know, those kinds of things that I could talk about. Again, if you really got stuck and you couldn't think of anything, and this is the only thing you could think of, by all means, throw it out there so you have something to say. And the worst they could ask you is, how do you do pelvimetry? You know,
Okay.
you know, and then you just be able to say, you know, honestly, I don't do it often enough that I'd have to check it.
Yep.
But again, I'd have to be pushed to say that, just from a technique standpoint.
Yep.
Okay, so if you have a patient that you take back for a C-section, like the patient I described, how are you going to manage it? So you're rolling her back to the operating room. What are you going to do in anticipation of this delivery, this C-section?
So first, I would potentially, I have done this before, I would potentially position her in a way that would allow for a vaginal hand to elevate the head out of the pelvis. So I could potentially put her in stirrups. I would also confirm with the nurse that we are doing a vaginal prep with iodine, with betadine. I would ensure that her anesthesia is adequate. Intraoperatively or preoperatively, I would give her Ancef and azithromycin for a clean contaminated case while this patient is after prolonged labor. I would, once I get to the hysterotomy, I would make sure that the hysterotomy is sufficiently high, but not too high that I'm getting past the rounds, because I do want to make sure that I'm not extending into the bladder when I'm attempting to deliver the baby. But I also don't want to be making a mid-transverse uterine incision. When I am delivering the baby, I would make sure that my hand my wrist stays unflexed, and it's straight in line with the rest of my arm. And I would have the vaginal hand pushing up on the fetal head as I'm doing this. If this does not work, I would also potentially consider using potentially delivering the fetus breech by grabbing the feet from the fundus, uterine fundus. If I do elevate the head up to the hysterotomy and I'm not able to get the head out, I would potentially consider a vacuum-assisted delivery.
Okay. All right. Very good. So let's go over it. The prevalence, it's about 1.5% of all C-sections. There's a deeply impacted fetal head, and it is occurs in about 25% of emergent C-sections. So it is a little higher with in emergent type C-sections. You mentioned the things that that can be associated with it. So maternal hemorrhage, you mentioned extension of the hysterotomy incision. So, you know, and it could go anywhere, but often could go down into the cervix and the vagina, and it's a nightmare to repair those if you've never done one. Obviously, bladder is at increased risk for injury. And you mentioned issues with the baby, including so traumatic injury to the baby or, you know, hypoxic event because it's taking more time to deliver the baby. So some risk factors, you mentioned macrosomia. So OP is about, this would be it occurs in about 10%, or is a 10% factor, I should say. Occiput transverse, you said prolonged second stage. Failed operative delivery would be another risk. If the diagnosis of the fetal position is complicated by caput, which it often is, which can lead to an error in your position. That happens in about 1 to 2/3 of cases where you may have an incorrect fetal position. So the treatment, as you mentioned, you want to let nursing know. Obviously, you let them know anyway because you're going to do a C-section, but you'd also want to let them know that you're concerned that the baby may be difficult to extricate from the pelvis. So anesthesia, neonatology, so you'd want to have peds present. As you mentioned, put the patient in a modified lithotomy so the nurse or someone could access the vagina from below to be pushing up. As you also correctly pointed out, you want to make your hysterotomy higher to avoid entry into the cervix or the vagina, again, due to the overdistension, if you will, of the lower segment. And again, the two techniques, there's the push technique from below, which you described. There's also a pull technique from above, so it's like a reverse breech. They have shown that the pull technique, interestingly, showed decreased maternal hemorrhage. There was also decreased hysterotomy extensions and infection. So something to consider. Can you guys hear me despite the slight echo?
Yes.
Okay. You can consider a J or T extension, or you could also consider a uterine relaxant like terbutaline or nitroglycerin. There are some fetal disimpacting systems. I think the pillow is one. You can try to deliver the shoulders through the hysterotomy, and then use axillary traction. I have no experience with this, and I can't describe it more than what I just told you. So the two big things would be, if not the pillow or the fetal disimpacting system, the two big things would be the push technique or the pull technique, again, with the pull technique seeming to have fewer complications. So I think that's it. Clarissa, any questions from you on this one?
What is the pull technique? You said it was a reverse, like a breech delivery, or is that what you?
Exactly.
Okay.
Yes. So yeah, that would basically be it. Any other questions?
No.
Very good. Thank you very much. Thanks for volunteering.
Thanks.
So let's see. Ijama, I'm going to mispronounce your name again. Are you available?
Yes.
The baby asleep yet?
Yes.
Oh, good. So, I mean, you know, it's your 5 minutes of peace and quiet for the day.
Correct.
Are you a generalist or a specialist?
Generalist.
Okay. Give me half a second here and I will give you the case. Okay, so you have a patient who comes in complaining of, or actually is referred in because she's just miserable during her menses. She's very depressed. She acts out at her colleagues and her family during her menses. So her primary care doc is suspecting PMDD. So they send her to you for evaluation. She is 24 years old and nulliparous. Obviously, you're going to take a detailed history, but what is PMDD?
The definition would be premenstrual dysphoric disorder.
Okay. So what is that?
So that's when prior to menses, patient will experience, like you said, certain changes in mood that affect their life. And so, like you were talking about, sometimes you get depression or anxiety or just some type of mood instability. It's usually in the luteal phase.
Okay. So how would you diagnose it?
Well, like you said, taking a detailed history and physical, or detailed history to determine when it all started and then what symptoms the patient experiences, and then also exactly when in the cycle that the patient experiences these different moods or these symptoms. And just kind of clinically and by the history.
Roughly, how common is PMS in the general population?
PMS, that one I am not for sure. I would imagine maybe 30 to 40%.
PMS 30 to 40%?
Yes.
Okay. What about PMDD?
I would say that would be less, more like 5%.
Okay. And what lifestyle modifications would you suggest for a patient that you believe has PMDD?
Lifestyle, any type of exercise or physical activity could help. Trying to think of, I'm not sure if it's related to the diet.
I'm sorry.
More, I said I'm not sure if it's more related to the diet, but more just like I said, the physical activity, some type of exercise to help.
So some type of exercise.
Yeah.
And what about any dietary changes you would recommend?
So I was just thinking about, I'm not too for certain on diet changes unless they experience or notice any change with any particular foods that they eat. We tell them to try to avoid those foods.
Okay. What about medications? Are there any medications you could offer the patient?
There's some antidepressant medications or anti-anxiety medications that could possibly help with the PMDD. More of, I guess, a mixture of like the ones like, I guess, I might have just been blank on the generic name, but I was thinking Zoloft. Okay, Zoloft or Wellbutrin, those type of medications.
What was the medicine though?
Zoloft or Wellbutrin.
Okay. So Zoloft or Wellbutrin.
Yes, and then you also try some birth control pills or hormonal contraceptive pills as well.
So if you were going to put her on a pill, what would you recommend?
A middle dose, like ethanol, estradiol / norepinephrine. I think the 1/20 microgram dose has worked in the past.
Okay. Any other medications you could try?
I can't think of any right now.
So, what about if the patient has disabling symptoms and I mean, she's nearly suicidal from all this? Is there anything extreme that you could offer her?
Like a mood stabilizer?
I'm sorry, I couldn't quite hear you.
I feel like a mood stabilizer.
Okay. All right, good. We're gonna phone a friend. They want to add?
Yes,
Laura?
please.
You want to take yourself off mute, Laura?
Yeah.
Great. Anything that you want to add to what we talked about?
Well, I think she did well naming the treatments: SSRI, OCPs, cognitive behavioral therapy,
That's the one.
and then different like stress reduction techniques.
Like what?
As for the diagnosis, I know that there's like multiple criteria that are made or that are needed, but I can't remember the exact numbers in which from each different category, but I know that there are multiple criteria.
Okay. Very good. All right, let's go over this one, folks. That way we'll have a few minutes. We can answer any last minute questions as well. All right, so PMDD, severe form of PMS. There's usually marked behavioral, emotional, possibly sometimes physical symptoms. So you need at least one severe affective symptom. So either marked depression, hopelessness, anxiety, affective lability, persistent anger, any of these occurring around the time of menses. And it's diagnosed using a validated screening tool. It's the daily record of severity of problems. And they need to have 2 consecutive cycles showing luteal phase symptoms. And you need to exclude other causes like anxiety disorders, thyroid dysfunction, substance abuse, or menopause. So the incidence for PMS is about 15 to 20% in the population, with about roughly 5%, which is exactly what you said, excuse me, of patients having PMDD. So in terms of lifestyle modifications, you suggested aerobic exercise, so that is definitely good. From a dietary standpoint, we would encourage the patient to decrease sugar, salt. Salt certainly could help with decreasing some of the physical symptoms patients might experience, like bloating. In addition, red meat, caffeine, and alcohol are also recommended to be reduced or used in moderation. Calcium and vitamin B6, interestingly, have been shown to have some benefit. Things that you mentioned, stress reducers, Laura, just a minute ago. So massage, yoga, biofeedback, primrose oil. The Chinese herbals, however, there's not enough evidence to recommend them. But, adequate sleep and any other stress reducers you can think of. There's not really good evidence for acupuncture either. Group psychoeducation can be beneficial for these folks. And then in terms of medications, SSRIs like Zoloft was mentioned. 60 to 70% of patients will have a positive response to SSRIs. So that's a good option. Cyclic birth control pills, particularly if the patient wants contraception. The only thing I would say differently, again, I'm going to mispronounce your name, Afuma?
Pajama.
Pajama, jeez. Terrible.
Like pajama with an E, that's fine.
I'm sorry. You would want to use a birth control pill containing drospirenone,
Just burn out. Okay.
Drospirenone is going to have a mild diuretic property, and it's going to be have probably the least androgenic side effects. And as we know, androgenic side effects can cause depression, and we want to obviously not add potentially to that. About 50%-ish of patients who use a drospirenone containing birth control pill do report some improvement with their pmdd. If the patient's having physical symptoms, NSAIDs would be okay. When we get to the more extreme cases, you could even consider a GnRH agonist like Lupron to suppress the ovaries. But again, if you're going to use it long term, the concern would be bone loss. In the most extreme cases, they even talk about considering a BSO for patients. But before you would ever consider that, you would want them to have had a successful trial with a GnRH agonist. So you would want to know, for example, by simulating menopause, let's say with Lupron, that they're better. So, at least you'd have a high expectation that your BSO is going to work, because obviously we wouldn't want to do a BSO, and that would be in an extreme case anyway. Do either of you guys have any questions?
No. No, I don't. Thank you.
Thank
Do
you.
you think that we have to be super specific about the number of like criteria made for this kind of case if it's like a structured case?
No, I
Okay.
don't.
Perfect.
You want to have a general idea of, treatments for it, roughly how you would diagnose it. Using a validated tool is always a good thing. But I don't think, and some of the numbers I'm throwing out at you are not absolutely critical, but having, high incidence, low incidence is probably adequate.
Okay. Perfect. Thank you.
You're welcome. All right, guys, we are at 9:54 Eastern time, so I'm going to put everybody's hand down. And I guess I'll go to the questions reluctantly, because I'm sure there's a million of them since I didn't take any while we were doing this. So let me just expand that a little bit. Okay, amniocentesis. Not sure what that is in reference to. So Jennifer, you can type in the question box if you're, amniocentesis was probably something we could do for the stillbirth. That is something that you could do. Not sure exactly what you'd get other than, if the amniotic fluid is infected. I'm not sure what else you would get that you couldn't get otherwise, although, because you would have to look, for example, for if you're looking for infection, which would be one thing. I think you're also talking about from a genetic standpoint. Theoretically, you should be able to get chromosomes from the baby and tissue to do microarray, but I have also seen that amnio might be preferred. So in a minute, I will come back to you and unmute you, Jennifer, if you want to make your point. Let's see, can we mute the other person? Sorry about that. Bad echo. Is it possible to? A lot of questions about the muting. I'm sorry, everybody's talking about the background noise we had on the one patient. Urine cytology, urinalysis can be done. Let's see, urine cytology, urinalysis. I'm not sure what that was in reference to, but I see she put another comment in. For Lynch syndrome, starting annually 30 to 35. Good point. I assume you're talking about looking for ureteral / kidney cancer. Good call. Thank you. Can you mute the other person? Let's see. stillbirth for genetic testing, thought it was most reliable. So it was the amniocentesis comment. I believe that, and this I'm not 100% sure, guys, I think that you can grow the cells or something more easily, or it's easier to get to assess for a genetic condition with the amnio. So certainly that would be something that could be done, and thank you for pointing it out. And then we just talked about the cytology, urine cytology and urinalysis. Certainly looking in the urinalysis, looking for blood would be something. So Jennifer has, let's see, amniocentesis for fetal karyotyping has the highest yield and is particularly valuable if delivery is not expected imminently. So again, this is from the practice bulletin, again, for stillbirth. So Jennifer, thank you for pulling that out for us and for also putting it in the question box. Okay, guys, I'm just gonna run through one more time. Does anybody have, now if you wanna put your hands up, if anybody has any questions about anything we talked about or just anything in general that I might or might not be able to help you with tonight, I'll be happy to try. Just looking through here. Okay, so a couple things, folks. I apologize for the one candidate that we had that where we were getting some feedback and y'all couldn't hear well. Hopefully whatever questions that I repeated it and you guys are comfortable with that. Also want to apologize for the long search, if you will, for the people whose names I was given to call on. I will speak to the Exam Pro folks to see if we can try to pare that down so that it's not as cumbersome next time. I will look forward to speaking with you guys next Tuesday. I will forewarn you, next Tuesday, I believe, is going to be changed from a caseless day to a case of the day or structured case day. I think they're trying to get one more of those in this month. So I will look forward to speaking with you all next Tuesday. In the meantime, I wish you all a good